Good evening. How are you all doing? Meeting after a long time today. Um, so today's class is going to be on leukodystrophies. So a pretty a difficult topic, I'd say, but I'm going to try and keep it simple. Tell you the pattern approach that you should have, and what are the specific pointers which will help us reach the diagnosis. So that's what the target would be. So just waiting for 1 or 2 minutes and then we'll start off. 1 minute early today. Next up, so just to tell you a bit about the upcoming schedule. So you're gonna have DNB OSCE coming up, model DNB OSCE day after tomorrow. So that's where we'll be discussing a bunch of spotters related questions. And then from next month, what I'm planning is we'll be having spotter quizzes, which will be system wise, so that it gives you better training, and in between we can have a few mixed bag as well. So that's what I'm planning. And then whatever will be the request that you guys keep sending, there are a few things which I want to complete, a few MSK rad topics, and then I'll take up your request, because then we would have touched upon almost all of the systems. So then we can go to specific topics, specific questions. Doppler demos should be uploaded by tomorrow. There were a few corrections which Dr. Binesh was working on, so which took a bit of time, but should be uploaded by tomorrow. I just spoke to the team today. Shall we start off now? Are you guys all set? Okay, so let's start. I think a few of you have joined. All right. So before we start with leukodystrophies, a few things which you should know, because only when you know what normal myelination pattern is, and what are the timelines here. Yeah, I feel a bit my throat is gone actually. So just because of that. Otherwise, I'm completely okay. Not tired. It's just the voice which is a bit sore. But all good. Thank you. So before we get to abnormal leukodystrophies, we want to know what are the normal, this thing. What is the secret of my energy? I'll show. See. Okay, so just finished a Red Bull before this class, because it's something which was very difficult topic. I had to read so much to prepare for this class. So that's the secret if you really want to know. All right. Anyways, so the rules of myelination that we were talking about, I think as residents, I don't know, when I was doing my residency, I was so addicted to caffeine, and it was starting to become a problem which I had to really cut down on. So residency does that to you, very weird. Everything, sleep cycle takes a hit and all of these things. So now I'm back into that zone. I feel, I don't know why. So yeah, you guys must be relating to this. Anyways, we'll chat later. So coming back to rules of myelination. So this is how this slide actually focuses on, how the normal pattern is, and then I'll take you into the diseases. Okay. So when we talk about the normal myelination, it starts somewhere close to, 5 months of gestation. That is when the myelination starts. And then it continues till about 18 months. It's at 18 months that the brain is almost ready, except a few areas. The few areas which are left at around 18 months are two things. It's mainly these fibers. This is what we call as the U fibers. So these subcortical U fibers are what are left out at the 18 months. So before I reach here, just to tell you a sequence of how this happens, it's always peripheral nerves before CNS. It's in the direction of nerve conduction. The concept here is myelination happens in the direction that the nerve wants to conduct. So as the signal comes from peripheral nervous system to central nervous system, that's how myelination proceeds. And again, caudal to cranial. From dorsal to and then from central to peripheral. So basically it is this periventricular white matter which is ready first, which is myelinated first. It's the internal capsule below this level which is myelinated first, and then it progresses, peripherally or centrifugally into the subcortical white matter. So that is important, and that's why this happens to be the last part to be myelinated. So just remember the concept here. It's in the direction in which we want to conduct. So sensory more than motor, and it happens first in primary and then in association area. So this is basically the concept or the theory behind myelination. So this is the progress. So more on this. So the first change is increase in T1 signal and later decrease in T2. So what this means is, let's just do this. How would the signal intensity of a myelinated white matter appear vis-a-vis non-myelinated white matter? So I think all of you know this. Whenever something is myelinated, as you put myelin to it, the water content decreases, so that's what is reflected here. So it's basically the decline in water content which reflects as the signal intensity. How I used to remember it was, myelin sounds like fat, it's something which is fatty. So I always used to remember it resembles a fat signal. Or the other way of remembering this is that the water content decreases. So myelin is opposite of fluid. Having said that, so it is T1 hyperintense and T2 hypointense. This is how normal myelinated white matter should look like, and what pathologies will look like, or what non-myelinated white matter will look like is going to be the opposite, which is going to be T1 hypointense and T2 hyperintense, which is pathological in general. So how do we distinguish pathology from normal non-myelinated? T2 hypo, why? Because water decreases, right? As myelin comes, the water content decreases. So water content decrease matlab T2 signal intensity drops down. That's why. Okay, that's how the white matter, as myelin comes, the water drops out. Getting it? Okay, so this is what is happening here. So how is this happening? So it's not both going together. First, what is manifest in the normal progression, that we were seeing in a normal baby, the myelination, but water is white. Yes, water is T2 hyperintense. So decrease in water will be T2 hyperintense decreasing, which is T2 hypointensity. Is that making sense? Is that very complicated? Fat is white. That's why I'm saying that's just what I was just telling you, a trick to remember. It's not myelin equals fat. Myelin is something which is coating. It's oligodendrocytes which are coming and coating the white matter. So I was just telling you an example to remember. It's not equivalent to fat. The real concept is whatever is myelinated is basically going to decrease the water content. I don't know how this is very difficult to understand. So what is normal signal intensity of water? Water is T2 hyperintense and T1 hypointense, right? So whenever I decrease the water content, the signal intensity will be opposite. I hope that is making sense. Yeah, so that is what you want to remember here. Okay, I hope that's clear. Okay. So here, the manifestation that you see on an MRI of a normal baby, who's between 0 to 18 months, we might see increase in T1 signal intensity in some areas, and then later on, we are going to see decrease in T2. You may not see the normal signal intensity everywhere. So this is the normal progression. So what is this order? So anterior limb. Before I get to anterior limb, what do you think posterior limb? This is something we see at birth, right? PLIC, posterior limb of internal capsule, is a very important milestone that we see at birth. And this is something which should be myelinated at birth. After this 2 to 3 months, we have anterior limb. Then we go to cerebellum, because we know it's center to periphery and it's craniocaudal. So cerebellum, anterior limb, it's posterior to anterior. So it's splenium which comes in, then comes the geno, and then it's going towards periphery. So, slowly subcortical white matter becomes bright, and then comes the geno. So we're seeing it's T1 bright followed by T2 dark. So everything is kind of ready by 18 months to 2 years. This is how the progression is happening. And the only unmyelinated part, so this is important because this is what we will have to learn to distinguish from pathology, right? So this is something which is the only part which is normally unmyelinated, which is called as terminal zones of myelination at 2 years, which is on the posterior aspects of the lateral ventricle. Okay, so you can see that this is T2 hyperintense. So I hope you guys understand this. Good question, Neha. So basically, it should reflect at the same time. It's just the visualization, you know. So I get it that it's a question, but it's the degree of myelination, you know. So something starts myelinating, and that is manifest first as T1 hyperintensity, and as the myelination progresses, it manifests as T2 hyperintensity. So it's more on the degree of myelination that the signal intensity is dependent on. Okay, so that's why there is a timeline to it, that पहले ये दिखेगा फिर ये दिखेगा, right? So that's why we look at T1. That's why what's the best sequence to assess white matter? It's what we see first. It's T1. And if you have a doubt with T1, we have a higher resolution, which is T1 IR image, right? Inversion recovery. So it's T1 or it's T1 IR that we are going to look at to, you know, see these diseases. So that's why it's the best sequence. Right. So coming back to this, so this is what you can now understand. Looks T2 hyper intense, whereas we know normal myelination is T2. It is T2 hypo, like the other myelin that you can see. So this is the only area which is abnormal. So this at 2 years, you should not interpret as abnormal is the only message I'm trying to tell you here. Okay. So I hope this normal is clear to you. Now, just a brief discussion on clinical feature. This is not something that thankfully we have to figure. This is something that the neurologist will identify, but we need to know the pattern at least, right? So you need to know what you're suspecting. So white matter so there are diseases, leukodystrophies, which are white matter only, or they are white matter plus gray matter. And when I say gray matter here, it's not the cortex, but it's the basal ganglia, which, you know, I'm focusing more on along with, you know, plus minus cortex. So white matter involvement is usually late, and, you know, children will have motor dysfunction, ataxia, and may or may not have megalencephaly. Whereas if basal ganglia is involved or cortex is involved, you'll have seizures. And this is what usually causes microcephaly. And because basal ganglia is involved, you'll have extrapyramidal signs. And these are in general, you know, buzzwords for any child who's suspected to have a leukodystrophy is failure to thrive, developmental delay, regression of milestones, may have psychiatric symptoms as well. So this is the usual imaging spectrum. Most of the times in your MR requisitions, you know, they'll talk about global developmental delay and motor abnormalities, and that's the non-specific history that we get. Now, a